Sometime in the last few years, you noticed it. Maybe you were in the shower, maybe you were putting on socks. Maybe someone else noticed first and said nothing because they didn't want to alarm you. The hair on your lower legs, from the knee down to the ankle or further, thinned, became sparse, or disappeared entirely. You assumed it was aging. Maybe you mentioned it to your doctor at some point and they said nothing, or they noted it and moved on, or they said it was just normal age-related skin changes. I need to tell you something today that nobody in that appointment said clearly. The hair on your lower legs does not disappear because you are getting older. It disappears because the arteries feeding your lower legs are narrowing, and the hair follicles, which are among the smallest, most metabolically demanding structures in your body, are the first things to go silent when the blood supply begins to fail. Those follicles are not aging, they are starving. The organ responsible for this is not your skin, it is not your hormones, it is not your immune system, it is your arteries, specifically the arteries in your legs. And what is happening inside those arteries right now, as you watch this video, is the same process that, if left unaddressed, leads to pain when you walk, wounds that will not heal, and in some patients, amputation. The condition is called Peripheral Arterial Disease, PAD, and it affects 8.5 million Americans over the age of 40. Most of them, at this moment, do not know they have it. I am going to show you the mechanism inside your arteries that causes leg hair to disappear. I am going to show you the other 4 signs that appear alongside it. Signs you have almost certainly noticed and attributed to something else. And I am going to give you the name of a specific test that takes 4 minutes and costs nothing, and that your doctor has almost certainly never performed at your annual physical. Stay with me. Because what I am about to show you is not a cosmetic observation. It is a cardiovascular report card. And for many of you watching right now, it is the most important thing you will learn about your own body this year. I want to tell you about a man named Dennis. Dennis is 67 years old. He spent his career as a high school principal. He came to see me not because he was worried about his legs. He came because his left knee had been bothering him for months and he thought he might need a cortisone injection. While I was examining him, I looked at his lower legs. Both of them, from the knee down, were completely hairless. The skin had a slightly shiny quality to it. One of his toenails had thickened noticeably. His feet were cool to the touch, noticeably cooler than his hands. I asked Dennis how long his legs had been like this. He said, "A while, maybe 2, 3 years. I figured it was just getting older. My dad's legs looked like that." I asked him, "Does your calf ever cramp when you walk a certain distance, like it gives out on you and you have to stop?" He looked at me. "I stopped walking to the end of the block about a year ago. I figured I was just out of shape." Dennis was not out of shape. Dennis had peripheral arterial disease that had been silently progressing for years. His arteries had been narrowing. His leg hair had been sending the signal the whole time. And nobody, not in any of his routine appointments, had ever connected those 2 things in the same sentence. We will come back to Dennis at the end of this video, because what happened next is the part I want you to carry with you. Before I show you the mechanism, I want to make sure you understand what this video is for, and what it is not for. This video is not here to frighten you. Fear without a path forward is useless, and I refuse to leave you in it. By the time we reach the end of this video, you will understand the mechanism behind what has been happening in your legs. You will know the 5 signs of peripheral arterial disease that appear before the pain starts, and you will know whether you have them. You will know the name of the test that reveals your arterial health in 4 minutes, and you will know exactly how to request it. And you will know something else. Something the hair loss, the cold feet, the nail changes, and the skin changes are all pointing toward. Something that, if it is caught at this stage, can be meaningfully slowed, managed, and in some cases partially reversed. There are 3 types of people watching this right now. The first type noticed the hair loss and never mentioned it to a doctor because it seemed cosmetic. You have been filing it under getting older and moving on. This video is going to change the category you file it under. The second type is diabetic, hypertensive, or has smoked at any point in their life. you are at the highest risk of peripheral arterial disease of anyone watching. What I'm about to show you applies to you more urgently than to anyone else in this video. The third type has none of the signs I will describe. Your legs are warm, your hair is present, your toenails are normal, and you are watching this because you want to understand what to watch for. Stay. Because the person sitting next to you in your next doctor's waiting room may have 4 of these signs and no idea what they mean, and after this video, you will. To understand why your leg hair disappeared, you need to understand what is happening inside the arteries that feed your lower legs. And I want to take you there, step by step, because once you understand the mechanism, everything else in this video will fall into place. The arteries in your legs are not just pipes. They are living structures, layered, flexible, responsive. The innermost layer, called the endothelium, is a single-cell thick lining that is in direct contact with your blood. When this lining is healthy, it produces nitric oxide, a molecule that keeps the artery wall smooth, relaxed, and open. Blood flows freely. Oxygen and nutrients reach every tissue the artery supplies, including the hair follicles on your lower leg. Now here is what peripheral arterial disease does to that system. Over years, often decades, a combination of factors begins to damage that endothelial lining. The primary culprits are the same ones your doctor has probably mentioned in other contexts: high blood pressure grinding against the artery wall, elevated blood sugar glycating the endothelial proteins, LDL cholesterol oxidizing and depositing beneath the lining, and in smokers, the direct chemical assault of tobacco compounds on the vascular tissue. As the lining is damaged, the body's repair system responds, but the repair process itself creates a problem. Inflammatory cells, calcium deposits, fibrous tissue, and oxidized cholesterol begin to accumulate inside the artery wall. This accumulation is called atherosclerotic plaque, and as that plaque grows, it narrows the interior space of the artery. Less blood can pass through, less oxygen reaches the tissues downstream. Now think about what is at the end of that downstream supply chain. Your femoral artery runs down the inner thigh. It branches into the popliteal artery behind the knee. That splits into the anterior and posterior tibial arteries, which run through the lower leg and divide further into the smaller vessels that reach your foot. The hair follicles on your lower leg sit at the very end of that chain. They are serviced by the smallest branches, vessels the width of a few cells across. When the pressure and flow in the large arteries upstream drops because of narrowing, the first structures to lose their supply are the ones at the farthest end of the smallest branches. Hair follicles are metabolically expensive structures. They require constant oxygen and nutrients to cycle through growth phases. When the supply drops below the threshold they need to sustain growth, they enter a state of dormancy. Then they atrophy. Then the hair stops coming back. This is not a skin problem. This is the most distal tissue in your body, reporting that its blood supply is compromised. Here's the analogy I want you to hold on to throughout this video. Imagine a garden with a complex irrigation system. Large pipes run from the main supply, branching into progressively smaller pipes that reach individual plant beds at the far end of the garden. Now imagine the main supply pipe begins to narrow. The plants nearest the source, the large beds close to the main line, continue to receive adequate water. They look fine. But at the far end of the garden, in the smallest beds fed by the thinnest pipes, the water pressure has dropped. The plants there start to fail first. They wilt. They stop producing. They go quiet. The hair on your lower leg is the plant at the far end of the garden, and the narrowing of the main pipe is peripheral arterial disease. Now I want to show you the 4 other signs that appear alongside the hair loss, signs that have the same root cause, that are happening in your body right now, and that most people have attributed to something completely different. Because when you see all 5 together, you will understand why this is a pattern, not a coincidence. I want to go through each sign the way I do with patients in my office, not as a list to check off, but as a conversation. Because each one has a specific mechanism, and understanding why it happens is what turns information into action. Sign 1 is the leg hair loss itself. We have already covered the mechanism in depth, But I want to add one clinical detail that most people do not know. The distribution of leg hair loss in peripheral arterial disease follows the blood supply. Because the posterior tibial and anterior tibial arteries supply the lower leg from the knee down, the hair loss typically starts at the lower shin and ankle and may be absent from the lower leg entirely while the upper leg and thigh remain normal. This is not coincidental, it is anatomical. The hair loss maps directly onto the arterial territory that is most compromised. If your leg hair loss is patchy or inconsistent, some areas bare, some areas with sparse regrowth, that variability reflects the pattern of arterial narrowing in the specific branches supplying those areas. And if you look at both legs together, is one side more hairless than the other? Asymmetry between legs is a particularly meaningful sign. It suggests more significant narrowing on one side, which can be confirmed with a simple measurement I will describe later in this video. Sign 2 is skin that looks different, shiny, thin, and tight. Look at the skin on your lower leg, not the color, the texture. In a healthy leg, the skin has a normal matte quality. It is pliable and has some give when you press it lightly. In a leg with compromised arterial supply, the skin becomes progressively thinner and tighter. It may develop a slightly waxy or shiny appearance. In advanced cases, it can look almost translucent, with the underlying tendons and veins more visible than they should be. This happens because the skin is the largest organ in the body and one of the highest demand tissues in terms of ongoing blood supply. As arterial flow decreases, the dermis thins. The sebaceous glands, the glands that produce skin oil, reduce activity because they, like hair follicles, need blood to function. The result is skin that is dry, tight, and fragile. This fragility is clinically important beyond the cosmetic change. Thin, poorly perfused skin does not heal well. A small scratch, an ingrown toenail, a blister from a shoe that rubs, any of these minor injuries in a healthy person would close within days. In someone with significant PID, that same injury may become a chronic wound. In diabetics with PID, it can become a wound that requires months of treatment. The skin change is a warning, not a danger in itself, but a warning about what will happen if a small injury occurs. Sign 3 is toenails that have changed, thickened, slow-growing, or yellowed. The nail bed is, like the hair follicle, a structure that requires continuous, adequate blood supply to function normally. When that supply drops, the nail matrix, the growth center at the base of the nail, slows its output. Nails grow more slowly. Because they remain on the nail bed longer, they thicken. Because the nail bed tissue is inadequately oxygenated, the nail may take on a yellowish or brownish discoloration. I want to be careful here because thickened toenails are also caused by fungal infection, and the two can be difficult to distinguish without examination. But there are clinical differences. Fungal nails tend to be crumbly and have a characteristic debris beneath them. Ischemic nails, nails from poor blood supply, tend to be smooth on the surface but uniformly thick, sometimes with a more opaque or matte appearance rather than the powdery crumbling of fungal disease. The question to ask is not just whether you have a toenail problem. The question is, do you have a toenail problem alongside hairless lower legs and cool feet? Because that combination points somewhere specific. Sign 4 is feet that are cool to the touch, especially one more than the other. Temperature is one of the most direct indicators of blood flow. The body maintains the temperature of its tissues by delivering warm, oxygenated blood through the arterial system. When arterial supply is reduced, peripheral tissues, the feet especially because they are the farthest point from the heart, begin to lose their baseline warmth. I want you to do something right now. Place the back of your hand on the top of your right foot, then on the top of your left foot. Hold it there for 5 seconds each. Are they the same temperature, or is one noticeably cooler than the other? Bilateral coolness of the feet can have several causes, but asymmetric coolness, where one foot is significantly cooler than the other, is a strong clinical indicator of unilateral arterial compromise on the cooler side. This is one of the first things I check when I suspect PAD in a patient who has not yet been evaluated. It costs nothing. It takes 30 seconds, and the finding, when it is present, has a high degree of clinical predictive value. Sign 5 is pain or heaviness when you walk, that disappears when you stop. This is the symptom that most people do eventually mention to their doctor. But many do not because they have attributed it to their knee, their hip, their back, or their fitness level. And because the pain resolves completely with rest, it does not feel urgent. The medical term is intermittent claudication. It comes from the Latin for to limp, and the pattern is highly specific. Pain, cramping, or heaviness that begins at a predictable walking distance forces you to stop or slow and resolves almost completely within 1 to 2 minutes of rest. The mechanism is elegant in its simplicity. At rest, your leg muscles need a modest amount of oxygen. The narrowed arteries can just barely deliver enough. But when you walk, the working muscles need 4 to 6 times more oxygen than at rest. The narrowed arteries cannot scale up to meet demand. Lactic acid accumulates. The muscle signals pain. You stop. The demand drops. The supply is adequate again. The pain resolves. This is called exercise-induced ischemia. It is the leg muscle equivalent of angina, the chest pain that occurs when coronary arteries cannot deliver enough blood to the heart muscle during exertion. And just as angina is a warning of coronary artery disease, claudication is a warning of peripheral arterial disease. If you have stopped walking a certain distance over the past year or two, not because of joint pain, not because of shortness of breath, but because your calf gave out on you, that pattern is not a fitness problem. It is an arterial problem, and it needs to be named correctly so it can be addressed correctly. Now I want you to do something before we go any further. Pause the video if you need to, or just check as I read this. First, sit in good light. Pull up your trouser legs or look in a mirror. Compare both lower legs from knee to ankle. Is the hair absent, sparse, or significantly thinner than your upper leg? Second, look at both sets of toenails. Are any thickened, yellowed, or slow-growing in a way that is not explained by a treated fungal infection? Third, run your hand along your lower shin. Does the skin feel tight, smooth, or thinner than it used to feel? Fourth, place the back of your hand on each foot in turn. Is one foot noticeably cooler than the other? Fifth, think about the last 6 months. Has there been any distance, a block, the length of a parking lot, a store aisle, where your calf cramped and you had to stop? If you answered yes to 2 or more of those, the rest of this video is the most important thing you will watch today, because the next section changes what your next appointment looks like. Peripheral arterial disease is often called a silent disease, but that description gives the impression that it produces no signals. It does produce signals. They are just not being read correctly. The hair loss is a signal. The skin changes are a signal. The nail changes are a signal. The cool feet are a signal. The stop-and-go calf cramp is a signal. The body has been communicating about the state of its arteries in multiple ways in multiple locations for years. The problem is not that the signals are silent. The problem is that nobody connected them. Let me tell you who is most likely to have significant peripheral arterial disease right now, without a diagnosis. If you have type 2 diabetes, your risk of PAD is 2 to 4 times higher than someone without diabetes. And diabetic PAD is more aggressive, more distal, meaning it affects the smaller vessels in the lower leg and foot more than the larger arteries in the thigh, and more likely to produce the silent form where claudication is absent because the neuropathy has also damaged the nerves that would signal the pain. This is the most dangerous combination. The arteries are failing, and the warning signal is muted. If you are diabetic and you have any of the 5 signs I just described, this is not optional information for you. This is the conversation you need to have at your very next appointment. If you have high blood pressure, even if it is treated, hypertension is one of the most powerful accelerants of arterial wall damage. The mechanical stress of elevated pressure damages the endothelial lining, accelerates the inflammatory response, and promotes plaque development in every arterial territory, including the legs. Treating your blood pressure with medication slows this process, but does not eliminate the damage that has already accumulated. This is why PAD screening should be part of the regular assessment for any adult over 65 with a history of hypertension, regardless of how well controlled their numbers are now. If you have ever smoked, even if you quit years ago, tobacco is the single most powerful independent risk factor for peripheral arterial disease. Smokers develop PAD 10 years earlier than non-smokers. Former smokers carry elevated risk for decades after quitting. The chemicals in tobacco smoke cause direct endothelial toxicity, impair nitric oxide production, increase platelet aggregation, and accelerate the entire atherosclerotic process simultaneously. If you smoked for any significant period of your life, the arterial changes from that exposure do not disappear when you quit. They become more slowly progressive, and they still warrant screening. If your cholesterol has been elevated for years, or if you have been on a statin, LDL cholesterol that is oxidized and deposited in the arterial wall is the raw material of atherosclerotic plaque. A statin reduces the ongoing supply of that raw material and has been shown to reduce the progression of PAD and to lower the risk of cardiovascular events in PAD patients. But a statin prescribed for coronary risk is not automatically a statin prescribed with awareness of peripheral arterial involvement. If you are on a statin and have never had a conversation about your leg arteries specifically, that conversation has not yet happened. I want to be direct about something here. Peripheral arterial disease of the legs and coronary artery disease of the heart share the same underlying process. They are expressions of the same systemic atherosclerosis. And research has consistently shown that patients with PAD have a significantly elevated risk of heart attack and stroke, not just limb complications. This means the hair loss on your lower legs is not just a vascular problem in your legs, it is a window into the state of your vascular system overall. When the arteries in your legs are narrowing, the arteries in your heart and brain are being subjected to the same process by the same risk factors. Understanding your peripheral arterial health is part of understanding your complete cardiovascular picture. Now, I want to show you the test. The specific test that answers all of the questions this video has raised. The test that can tell you, in 4 minutes, whether the arteries in your legs are delivering adequate blood and what level of risk you are carrying. It is not a scan. It is not an MRI. It requires the same blood pressure cuff sitting in your doctor's exam room. And there is a very specific reason it is almost never done at a routine physical. The test is called the ankle brachial index, the ABI. It is one of the simplest, least expensive, and most informative tests in vascular medicine. And it is one of the most systematically underperformed tests in primary care. Here is how it works. A standard blood pressure cuff is placed on the arm and the systolic blood pressure is measured. Then the same cuff is placed on the ankle, just above the ankle bone, and the systolic pressure is measured there as well, using a handheld Doppler probe to detect the pulse. The ankle pressure is then divided by the arm pressure to produce a ratio. In a healthy arterial system, the pressure at the ankle should be equal to or slightly higher than the pressure at the arm. Blood pressure does not drop significantly as it travels from the heart down to the ankle in a healthy artery. The ratio should be 1.0 or above. When arteries are narrowed, pressure drops across the narrowing, just as water pressure drops downstream of a partially closed valve. So a narrowed leg artery produces a lower ankle pressure relative to the arm pressure. The ratio falls. Here is how to read the result, and I want you to write these numbers down. An ABI of 1.0 to 1.4 is normal. The arteries are delivering adequate pressure to the ankle. PAD is unlikely. An ABI of 0.9 to 1.0 is borderline. Mild arterial changes may be present. Monitoring and aggressive risk factor management are appropriate. Repeat testing in 1 year. An ABI of 0.7 to 0.9 indicates mild to moderate PAD. Symptoms may be present or absent. The arterial narrowing is measurable. A treatment conversation is warranted. An ABI below 0.7 indicates moderate to severe PAD. Significant narrowing is present. Further imaging, duplex ultrasound or CT angiography, is needed to map the location and extent of disease. An ABI below 0.4 is critical limb ischemia. The tissue of the lower leg and foot is receiving inadequate blood to maintain viability. This is a surgical emergency. There is one important caveat I need to give you, particularly if you are diabetic. In patients with long-standing diabetes, the arterial walls can become calcified and incompressible. A A calcified artery does not compress under the cuff pressure the way a normal artery does, which means the measured ankle pressure is artificially high. The ABI may read as normal or even elevated when significant arterial disease is present. This is called a falsely elevated ABI. If you are diabetic and your ABI appears normal but you have symptoms or signs of PAD, ask specifically about toe brachial index or duplex ultrasound testing. Now, here is the part that explains why you have likely never had this test. The ABI requires a Doppler probe, a small handheld ultrasound device, to accurately detect the ankle pulse. Most primary care offices do not have one, or do not have trained staff available to perform the test. There is also a billing and time reality. The ABI takes approximately 4 minutes to perform, is reimbursed at a relatively low rate, and is not included in the standard physical examination checklist that most practices use to structure their time. This is not a conspiracy. It is a structural failure of how primary care time and equipment are allocated. But the consequence of that failure is that millions of patients walk out of routine physicals every year with 5 signs of peripheral arterial disease on their lower legs and no evaluation of those signs. You can change that for yourself, and I will show you exactly how in a moment. Before I give you the exact words to use, I want to show you what happens if PAD is found at this stage versus what happens if it is found later. Because the stage at which this is caught is almost entirely determined by whether someone asked for the test, not by how severe the disease is, not by how many symptoms you have, by whether you knew to ask. Peripheral arterial disease caught at the stage of hair loss and mildly reduced ABI is a very different clinical situation from peripheral arterial disease caught at the stage of rest pain, non-healing wounds, or critical ischemia. At the early stage, the interventions are medical and lifestyle-based, the same interventions that protect your coronary arteries. They are not exotic, they are not expensive, but they require that someone name what is happening so that they can be specifically targeted. The first is statin therapy. Statins reduce cardiovascular events in PAD patients by approximately 25 to 30%. But specifically for peripheral arterial disease, statins have also been shown to slow the progression of claudication and to reduce the risk of limb complications. If you have confirmed PAD and are not on a statin, that is a specific gap in your management that warrants a conversation. The second is antiplatelet therapy. Low-dose aspirin or clopidogrel, depending on your individual risk profile and other medications, reduces the risk of thrombotic events in PAD patients. I want to be clear, this is not a recommendation to start aspirin without medical advice. The 2022 guideline change around primary prevention aspirin does not apply to patients with established vascular disease. What I am telling you is that if you have PAD and are not on any antiplatelet agent, that is a clinical conversation that needs to happen. The third is blood pressure control. The same elevated pressure that damaged the arteries in the first place continues to damage them. Tight blood pressure control, targeting systolic below 130 in most PAD patients without severe disease, slows the progression of the arterial changes. The ACE inhibitor class of blood pressure medications has been specifically studied in PAD and shown benefit beyond blood pressure reduction alone. The fourth is supervised walking exercise. I know that sounds counterintuitive. If walking causes calf pain, how does more walking help? Here is the mechanism. Supervised walking exercise, where you walk to the point of mild claudication, and then rest, then walk again, done consistently over weeks, stimulates the development of collateral vessels. Your body builds new small blood vessel branches that bypass the narrowed segment and restore partial flow to the downstream tissue. Multiple controlled trials have shown that supervised walking programs improve claudication distance, the distance you can walk before pain begins, by 100 to 150% in 12 to 24 weeks. In some patients, the improvement is greater than what is achieved with medication alone. The exercise does not reverse the arterial narrowing, but it changes what that narrowing means functionally. The fifth is smoking cessation. If you are still smoking and you have peripheral arterial disease, smoking cessation is the single most impactful intervention available. Not a statin, not surgery. Quitting smoking. The rate of PADI progression in active smokers versus former smokers is dramatically different, and the response to every other treatment, medication, supervised walking, surgical revascularization if needed, is significantly better in patients who are not smoking. Here is what I want you to understand about all of these interventions. None of them require a surgical procedure. None of them require expensive equipment. Most of them are conversations that can happen at your next appointment, if you come in prepared to have them. And if your peripheral arterial disease is at the stage where hair loss and early ABI reduction are the primary findings, you have arrived at exactly the right moment, early enough for every one of these interventions to have meaningful impact. Now let me bring it back to Dennis, and then I am going to give you the exact language for your next appointment. A single set of sentences that you can use to open the conversation that should have been opened years ago. Dennis came back to see me 3 weeks after that first appointment. He had had an ABI performed at a vascular lab I referred him to. His right leg, 0.72, his left leg, 0.68, both in the mild to moderate PAD range. The left leg, the side where his toenail was thickest and his foot was coolest, was more involved. His primary care physician had never performed an ABI, not in 12 years of seeing Dennis. Not after years of treating his blood pressure and his cholesterol. The 5 signs had been present, visible, and unread at every single appointment. Here is what changed after the ABI. Dennis's cardiologist, who had been managing his statin dose purely based on LDL targets, now had a specific reason to optimize the statin for vascular protection rather than just lipid numbers. His internist added clopidogrel after reviewing his full cardiovascular picture. Dennis enrolled in a supervised walking program at a rehabilitation center. He started walking to the point of mild calf discomfort and resting 3 times a week. At his 12-week follow-up, he could walk 3 times the distance he could at the start. His ABI had improved slightly on both sides. His cardiologist's notes said, patient demonstrating excellent collateral development. Dennis called the hair loss the most useful cosmetic change I ever had. He said, I spent 3 years blaming those legs for getting old. Turns out they were trying to get my attention. Write this down or replay this section. These are the exact words to use at your next appointment. Say this. I've noticed several changes on my lower legs that I understand can be early signs of peripheral arterial disease, specifically hair loss below the knee, skin changes, and toenail thickening. I also have, and here you name your relevant history, hypertension, diabetes, or a smoking history. And I'd like to request an ankle brachial index to screen for PAD. I'd also like to discuss whether my current cardiovascular risk management specifically addresses my peripheral arterial health, or whether there are additional steps we should be taking. If your doctor tells you the test is not available in their office, say this. Can you refer me to a vascular surgery or vascular medicine practice for the ABI? I understand it requires a Doppler device, and I'm happy to go elsewhere for the test. And while you are there, ask about 4 specific tests. First, the ankle brachial index itself. That is the primary test. Second, a lipid panel with LDL to confirm your statin dose is optimized for vascular protection, not just lipid targets. Third, fasting glucose and HbA1c to confirm or rule out diabetic or pre-diabetic status, which escalates PAD risk and changes management. And fourth, a comprehensive metabolic panel to establish a baseline for kidney and liver function before any medication changes. This is what this channel does. Your doctor has 12 minutes. This video gave you what 12 minutes cannot. You now know what peripheral arterial disease is, how it begins, and what 5 signs it leaves on the surface of your legs while it is still early enough to be meaningfully addressed. You know the name of the test, how to read the result, and what the management looks like at every stage. And you know something else now, something Dennis told his son after that 12-week follow-up. He said, The legs were never the problem. The legs were the message. I just finally found someone who could read it. After this video, you can read it too. One question before you go. Look at your lower legs right now. Whether you're sitting in a chair or lying in bed watching this, look at both of them and tell me in the comments what you see. Are both legs the same? Is one side different from the other? How long has it been like this? I ask because I read every comment. And because I know from years of these conversations that someone watching tonight is going to see something in their own legs that they have been ignoring for 2 years. And your comment, the one that says, I checked and may be the thing that makes the person reading it below you finally make the appointment. If this video gave you something you did not have before, subscribe. Free. This is what we do here every single time. Give you the 60 minutes your doctor cannot. And when you write to me, I write back.